CPC, we have a 40-year-old female who has non-resolving pneumonia, and she was a diagnosed case of CLL, and I'll request Dr. Pankaj Malhotra to present the clinical profile.
Good morning. So for today's CPC, we have a 40 years old female from Jalandhar. She was admitted last year July with fever, cough and expectoration of 1 week duration. She had a significant background history in the form of, in January 2019, she had non-specific fever, and at that time the CBC showed very high WBC count, and PBF showed 94% atypical cells with smudge cells. Flow cytometry was suggestive of CLL. A fish cytogenetics was also done from Jalandhar, which showed trisomy 12, and she had high LDH and she was referred to PGI. She came to PGI in March 2019 when the flow cytometry confirmed the diagnosis of CLL. She was RI1. In the viral marker, she had anti-HBC positive, but HBV DNA was less than 20. She was given tenofovir for a month, but then it was stopped. For CLL, there was no clear indication of therapy at that particular time, so she was kept on observation alone. However, if you can see the serial CBCs from 2019 till March 2020, there was progressive fall in the hemoglobin. Initially, it was iron deficiency anemia. And later here in March 20, just before the COVID lockdown, she underwent a bone marrow examination. And after the bone marrow examination, she was given a course of prednisolone 1 milligram per kg for a month. However, there was a COVID lockdown after that, and from the attendant, the history is that she responded to the treatment and her hemoglobin went up. Then she was remained asymptomatic until July 2021 when she is admitted with 1 week history of fever, cough and expectoration and shortness of breath. Another significant history in the past is that she received empiric ATT for 6 months in 2016 for suspected pulmonary tuberculosis. So at the time of examination, she has tachycardia and tachypnea. However, the saturation was 96% at room air. She had generalized lymphadenopathy in cervical, axillary, inguinal area. In the respiratory system, there were coarse crepitation and bronchial breath sounds. She stayed for approximately month and a half, and you can see that she had persistent severe anemia for which she received multiple transfusion, RBC transfusion. The WBC count remained high, and here she was given a course of chlorambucil prednisolone form of chemotherapy, and you can see there is some drop in the WBC count, which again was going up. The platelet remained low, severe thrombocytopenia, and she was receiving platelet transfusion. In the coagulogram, D dimers were high. The hemolytic workup was negative. The immunoglobulin levels were on the lower side. IgG was 6.26, although theoretically this is normal, but this is on the lower side. In the biochemistry, RFT remained stable. Bilirubin towards the end was little high. LFT was also okay. And LDH was higher towards the later part of the stay. Procal was also a little high in the later part of the stay. She had multiple sputum cultures which showed Acinetobacter baumannii initially for the first 10 to 15 days, and later on Pseudomonas aeruginosa, which was sensitive initially to most antibiotics, and later on it was resistant. She also underwent bronchoscopy and a ball which showed Pseudomonas as well as septate hyphae, and in the culture it was Aspergillus flavus. Glectomenin was available at the later part of his hospital stay, and it was high towards the end of her hospital stay. Beta G was also little high. In the ABG, she had respiratory alkalosis initially, which was later on a mixed picture of metabolic acidosis. And she was intubated here on 25th of August because of progressive anemia and put on mechanical ventilator. So in the course and management, she was diagnosed case of CLL, and this time she was admitted with a diagnosis of bronchopneumonia. CT chest showed consolidation. She received antibiotics. In fact, she received multiple antibiotics and antifungal from the beginning only. She underwent bronchoscopy, and a bowel fluid also showed septate hyphae. Because of severe anemia and thrombocytopenia and lymphadenopathy, a possibility of Richter transformation was also kept, and she underwent CT-guided FNAC from the lung consolidation, which shows infiltration by CLL only. And as mentioned, she received multiple courses of antibiotics from piperacillin, tazobactam, minocycline, colistin, vancomycin, imipenem, and antifungals, both voriconazole and amphotericin B, in sequential manner. However, there was a waxing and waning response to lung infection. She had persistent vomiting, and upper GI endoscopy showed bulge in the posterior wall of duodenum because of lymphadenopathy. She was supplemented with a course of IVIG also. She was also given 5 days course of chemotherapy with chlorambucil prednisolone, however, with no response. She continued to have fever, cough and breathlessness, and in the last few days she was put on mechanical ventilator. However, her pneumonia did not respond and she succumbed to the illness. The final diagnosis was chronic lymphocytic leukemia, progressive disease, query transformation, and non-resolving pneumonia, mixed picture, either bacterial or fungal. So I would invite now the bone marrow to show the bone marrow findings of the this patient. Dr. Shah.
Good morning. At the time of presentation in March 2019, we received peripheral blood which showed a hemoglobin of 10 gram per deciliter, platelet count of 1,05,000 and TLC of 1,08,000. The predominant cell population was of atypical lymphoid cells, which were 88%. These were small in size, having irregularly clumped chromatin and scant cytoplasm. Smith cells were also seen. Further on, flow cytometric immunophenotyping was done, and these cells were found to be positive for CD19, dual positive for CD5, 23, 43, heterogeneous CD20, CD200. They were negative for CD79B, kappa lambda 10, 34, and the immunophenotype and morphology were consistent with chronic lymphocytic leukemia. FISH analysis was also done for 11q and 17p deletion, which was negative. About a year later, in February 2020, bone marrow examination was done because of persistent anemia. So what was seen in the peripheral blood, that the hemoglobin had decreased to 6.1 gram per deciliter, platelet 87,000 and TLC had increased to 2,17,000. The predominant cell population again in the peripheral blood and in the marrow was of atypical lymphoid cells, which had similar morphology like that of diagnosis, being small in size. The bone marrow biopsy showed diffuse infiltration by these atypical lymphoid cells. The second marrow was done in July 2021 at the time of her last observation because of severe pallor, increasing lymph node and splenomegaly. The peripheral blood again showed a very low hemoglobin of 6.5 gram deciliter. Platelet had further decreased to 43,000. TLC increased to 2,23,000. The predominant cell population was of atypical lymphocytes, which were 91% in peripheral blood and 96% in bone marrow. Here we can see the morphology of these lymphocytes are small in size, similar to that we saw at the time of diagnosis. Many smudge cells were seen, but however, no large cells were seen. The biopsy again showed diffuse infiltration. Flow cytometry was also done at this time to see if there was any change in marker expression. However, the cells showed similar profile like that at the time of diagnosis, being positive for CD19, 523, 43, 20, 200. FISH was also done, which showed negativity for 11q and 17p deletion. So this time patient had diffuse infiltration. It was a progressive disease because of decreasing hemoglobin and platelet count, increasing TLC. However, no large cells or evidence of Richter transformation was seen in the bone marrow. Thank you.
Now I invite cytologist Dr. Sangmitra and followed by Dr. Sridhara from radiology.
So this is the FNA that was done from the lung lesion. So the smears were hemodiluted, but in this power we can see that there are few scattered cells. On higher power, we can appreciate that these are all lymphocytes, which are all uniform sized, and they are small, probably 1 to 1.5 times the size of a mature lymphocyte. And these are under the oil immersion field, where we can see irregularly clumped chromatin and a very scanty kind of a cytoplasm. So these features are of infiltration by CLL. followed by which we had received a BAL sample. This is a smear where we can see that there is some amount of respiratory mucin in the background along with few dispersed cells. And again, in the BAL, we can see the predominant population here is lymphocytes. Now, this is the LBC smear where again we can see that the predominant population is lymphocytes along with few neutrophils and alveolar macrophages. Again, these features are consistent with CLL infiltration.
Good morning, all. In the radiological database, we have multiple sets of X-rays and chest done for this patient. Due to time constraints, I'll be showing only the limited images. This is just the overview of all the X-rays that we have. The first X-ray we have is of 27th of July. However, in the CT, we have a 15th of July, which was day before admission. I'll show subsequently. What we can see here is that there are A-space consolidations or opacities in the right upper and mid zone with few nodular opacities, which shows partial response in the X-ray done on 14th of August. Again, in the later dates, we can see that there is full-blown infection with multiple nodular A-space opacities, which is extensive in bilateral lungs. So it is suggesting that there is some response to the treatment and there is exacerbation. Coming to the chest, the first CT that we have is done on 15th of July, that is just one day prior to the admission. Here we can see this multiple, there are nodular opacities in the right upper lobe as well as the superior basal segments of the right lower lobe. And along these nodules, we can see there is mild surrounding GGOs as well. In addition to it, we can also see there is large, dense mass-like consolidation in the left lower lobe with areas of air bronchograms. Here also we can see there are multiple thick nodules with surrounding GGOs. In the mediastinal window, we can see there are multiple enlarged bilateral axillary lymph nodes, few enlarged pre and paratracheal lymph nodes, consistent with the CLL status. And this is the mediastinal window to show that there is a dense-like, mass-like consolidation in the left lower lobe with the air bronchograms. So based on these images, we kept a possibility of a fungal infection because there are multiple nodules in the right upper and lower lobe with surrounding GGOs. And the mass-like consolidation in the left lower lobe can be associated with the fungal infection. And there is also a possibility of secondary lymphomatous infiltration of the left lower lobe. Subsequently, 10 days later, we have another CT done for this patient. What we can notice here is that the previously appreciated large, well-defined nodules with the GGOs have resolved. There is significant resolution of the previously appreciated nodules in the right lung, as well as the mass-like dense consolidation also shows a cavitation with the central soft tissue in the left lower lobe, possibly suggesting a fungal etiology, which are partially responding to the treatment. But in addition to it, there is a new dense consolidation seen in the right lung, peripheral subpleural location with surrounding GGOs. And another new opacity that is noted in the superobasal segment of the right lower lobe. So in this CT, we can see that there is some partial resolution of previously appreciated nodules with few nodules appearing, suggesting probably a superadded bacterial infection. Again, then 10 days later on 11th of August, this patient underwent a one more CT. What we can notice here is that the previously appreciated dense consolidation is again showing a central cavitation and partial resolution. So there is some response to the treatment. Again, even this one also shows mild reduction in the size of this mass-like consolidation with the central cavitation. But there are some few newer nodules started appearing in the right lung. In the same time, patient also underwent a CT abdomen. Here we can see there is a gross hepatosplenomegaly with multiple well-defined hypodense nodules in the liver, as well as in the spleen, possibly suggesting a lymphomatous infiltration. In addition to it, we can see there are multiple enlarged lymph nodes in the retroperitoneum as well as in the mesentery. These lymph nodes are multiple enlarged without compressing the vessels, which is consistent with the lymphomatous infiltration. This is the last CT that we have, which was almost done 8 days prior to the demise. Here we can see that though this previously noted consolidation was showing a response with reduction in size, central cavitation, but there are new onset of dense consolidation patches in the right lung, in the upper lobe as well as lower lobe. This is a MIP images just to show that the new onset nodules as well as consolidation patches in both the lungs. So at the same time, patient also underwent a CT pulmonary angio just to rule out any pulmonary thromboembolism. There was no obvious thromboembolism in the major vessels. And this is the last X-ray, just 2 days prior to the demise, again, which shows that the extensive full-blown infection with the multiple airspace opacities in both lungs involving all the zones. So to summarize, with all the radiology that we have, this patient has a generalized lymphadenopathy which has axillary, mediastinal, abdominal, retroperitoneal, mesenteric lymphadenopathy with hepatosplenomegaly and hypodense lesions in liver and spleen, which can be consistent with the patient's primary disease status, CLL with lymphomatous infiltration. The lung, we have a multiple Rantel nodules with areas of consolidation in both lungs, which shows resolution at places and exacerbation, so which may be suggestive of a fungal etiology with secondary superadded bacterial infection. And the mass-like dense consolidation in the left lower lobe can be consistent with the pulmonary infiltration by the lymphoma. Thank you.
Thank you, Sridhara. So, coming back to the discussion of this patient. Okay. So, I would start with a famous quote. Actually, quote was already there. It became famous a decade back by the Defense Secretary of the US. So, there are knowns, unknowns, knowns, which mean things we are aware and of understand. Known unknowns, things we are aware of but we don't understand. Unknown knowns, things we understand but are not aware of. And unknown unknowns, things we are neither aware of nor understand. So, part 1 of my discussion is known knowns, which means the diagnosis of CLL in this patient is clear. There is a presence of more than 5,000 B lymphocytes in the peripheral blood for the duration of at least 6 months. And we have the absolute lymphocyte count, which is in lakhs, 92% in the peripheral blood film. And we also have a flow cytometry, which confirms the diagnosis of CLL in this patient. Now, this patient was young. The median age of CLL in the West is around 65 to 70 years. But in this patient, this patient is 40 years and whether CLL can occur at 40 years of age. And for that, we have real world data from our department, where we have 30% of patients who are less than 55 years of age. Whereas in the West figure, this is only 10%. So this is, consistent in the Indian setting. This patient also has trisomy 12 on fish cytogenetics. So we also have a paper from Dr. Shano looking at the genomic alterations. And trisomy 12 is found in approximately 13% of patients. In the West, this figure is approximately 20% or so. Now, once you make a diagnosis of CLL, the next is to make a risk stratification of CLL, and for which we have a CLL International Prognostic Index based on the age, clinical stage, beta-2 microglobulin, IgHV status, and fish cytogenetics. So in this patient, the age was 40 years. She was at presentation RAI 0. Beta-2 was high. And she had fish examination which showed trisomy 12. IgHV status is not available in this patient. However, Dr. Dipesh from our department has modified the IPI to modified CLL IPI. In place of IgHV, we have using a lymphocyte doubling time to predict this. So this patient actually falls into the intermediate category of CLL. Now, when we say the intermediate category, exactly, there is always an overlap, because this classification is based by the humans only, and there is always an overlap. So low, high, and very high can overlap with the intermediate category also. Why I say so is, in this patient has a high LDH at presentation, and we know the elevated LDH has a prognostic relevance in the treatment of CLL with trisomy 12, and these patients have shorter progression-free survival. This patient was also young. So if you look at the data from the young patient, CLL in less than 55 years of age, this is a series from the Mayo Clinic. The young patients actually have adverse prognostic markers more than the elderly population. Now we go to the knowns, unknowns knowns. That means things we understand but we are not aware of. And that is trisomy 12 actually falls into the intermediate category. But we know that there are some patients with trisomy 12 who have a worse outcome in CLL. If we are able to detect Notch1 mutation in these patients, and if Notch1 is present, then this puts this category into a high-risk kind of a category. So I feel that this patient has an accelerated CLL or a Richter transformation. She was given a course of chlorambucil prednisolone even in presence of non-resolving pneumonia, just to take care of this, but there was hardly any response to this therapy. Now the part 2 of my discussion is on again knowns, that means the risk of infections in CLL, and for that I take the help of this paper which looked at the immune defects in chronic lymphocytic leukemia, and we can divide into primary and secondary. In the primary, these patients have B cell defects in the form of hypogammaglobulinemia, poor response to vaccination. These patients also have T cell defects both in quantitative and in qualitative forms. These patients also have NK cell defects, lack of granules and reduced killing activity. These patients also have neutrophils defect, reduced phagocytic and bactericidal function, abnormal migration and chemotaxis. They also have monocytes and macrophage reduced cytotoxicity. And finally, even the complements levels are low in these patients. The secondary obviously are due to bone marrow failure due to advanced disease, and if the patient has received any chemotherapy. And when you look at the etiological agents, so bacteria are the most common, but fungus are also there. Now we go to the category of known unknowns. One of the thing, generally in CLL patients, we don't do the FNAC of the lymph node or biopsy of the lymph nodes. However, in this patient, I think retrospectively, I think we should have done, because one of the, this series, which is looking at the infectious lymphadenitis in patients with CLL, this is a large series from Mayo, where 10% of patients actually underwent an FNAC or biopsy to evaluate for the progressive disease. Majority of the biopsies showed progressive CLL only. However, 9% shows second lymphoid malignancy, 4% infectious lymphadenitis, 1.1% reactive adenitis, and 0.6% non-hematological malignancies, which basically means that in a patient like this, probably an FNAC or a biopsy could have been done. Now, known knowns, lung consolidation, we are sure. The sputum showed Acinetobacter baumannii, and she was given minocycline and azithromycin at the time of presentation. The risk factor for the development of Acinetobacter baumannii are actually in this patient immunosuppression and malignancies. She was receiving corticosteroids on the OPD basis. Now, what unknowns are that, even at presentation, she had fungal nodules. The invasive fungal infections in CLL patients are seen in 0.5 to 18%. And again, the CLL patients with unfavorable prognostic profile are more affected by the invasive fungal infections. And in the other series, it is approximately 4% or so. So this patient was given voriconazole, and you can see that there was some response to the nodules which were present in the first CT scan. Now, part 3 of this patient is known unknowns. That means this patient had non-resolving pneumonia, and I'm just projecting the X-rays again. There was some response, but it was persisting, and later on in the sputum, it was Pseudomonas aeruginosa, and bile galactomannan was high, and the bile fluid showed septate hyphae and aspergillus pneumonia. So what is the definition of non-resolving pneumonia? It is a slow resolution or persistent pneumonia and failure of radiographic resolution by 50% in 2 weeks' time. So the key points in non-resolving pneumonias are malignancy is a common cause of non-resolving pneumonia, and our patient has that. We could not find airway obstruction. There was pulmonary embolism was ruled out by the CT scan, and the bronchoscopy and CT guided biopsy were done in this patient, which showed infiltration by CLL only. The causes of non-resolving pneumonia in forms of bacterial infection and tuberculosis and fungal infection. Now, I would mention a little bit about the tuberculosis because this patient had a past history of pulmonary cox, and she did receive prolonged steroids in this patient. I'm coming to the last slides only. So, the cause of non-resolving pneumonia, again, tumor causing airway obstruction, infiltrative appearance, lymphoma, lymphangitis, carcinomatosis, and pulmonary embolism and infectious complications. Now, known unknowns, one of the things which I should mention, even though, this patient did not receive COVID vaccination and repeated COVID was negative. So this patient, one of the possibility may be COVID, and this is the COVID series from 19 centers in India, where CLL patients were included in non-Hodgkin's lymphoma, and the overall mortality was, high in these patients. So finally, coming to the known unknowns, so this patient has CLL, accelerated or Richter transformation and aspergillus pneumonia. Known unknowns, pulmonary tuberculosis or a CMV pneumonia. The unknowns known, CL infiltration of lung. Unknown unknowns obviously will be presented by the histopathology only. So with that, I come to the final diagnosis of CLL with accelerated phase or Richter transformation. Non-resolving pneumonia, fungus is definitely there, and possibly gram-negative bacteremia, query pulmonary tuberculosis, and infiltration by CLL. With that, I thank you very much for your kind attention.
And good morning, everyone. I'll be presenting the pathology protocol in this 40-year-old female with a hospital stay of 1.5 months at her last admission and a clinical diagnosis of chronic lymphocytic leukemia, progressive disease, query Richter transformation with non-resolving pneumonia, query bacterial, query fungal. This was a complete autopsy, and the serous cavities were found to be within normal limits as per the prosectors. I'll start with the organ of basic disease. So this is the post-mortem bone marrow section, which shows marrow spaces which are hypercellular for age, along with multiple friable and thinned out bony trabeculae. These are the HiPAR images to show a spectrum of findings. There were areas of patchy bone marrow fibrosis, along with infiltration of the bone marrow spaces by atypical mononuclear cell population. The other hematopoietic bone marrow elements were markedly suppressed, and only occasional megakaryocytes could be identified, along with few hemostridin-laden macrophages. Further, the focal presence of these hemostridin-laden macrophages was highlighted on the Pearl stain. The reticulin was slightly increased to a score of 2+. The PS Alcian blue stain in the bone marrow sections highlighted areas of mucinous degeneration, while the Mason trichome stain highlighted the thinned out bony trabeculae, suggesting osteopenia in this patient. Further, on IHC panel, the atypical mononuclear cell population stained positive for CD45 and CD20, while CD3 was negative in these cells and only highlighted in the scattered T lymphoid cells, and this corresponded to the antemortem findings of bone marrow infiltration by CLL cells. So diagnosis on the post-mortem bone marrow section is hypercellular bone marrow with infiltration by CD45 positive, CD20 positive, and CD3 negative mononuclear cells, causing a total replacement of the normal hematopoietic elements consistent with chronic lymphocytic leukemia. The small and the large bowel on gross examination were unremarkable on the mucosal aspect. However, there were multiple enlarged and congested pericolic lymph nodes measuring almost 1 centimeter in the longest dimension. In addition, there were also multiple enlarged mesenteric group of lymph nodes. On microscopic examination, these enlarged lymph nodes showed a thickened capsule with the loss of nodal architecture of the underlying lymph node parenchyma due to presence of these diffuse population of atypical mononuclear cells, which could also be seen infiltrating into the surrounding perinodal soft tissue, suggestive of infiltration by leukemia cells. This is the HiPAR to show this atypical mononuclear cell population within the lymph node, along with many proliferating endothelial cells. Further, these atypical cells again stained positive for CD20, while the CD3 was highlighted in the scattered T lymphoid cells. The small and the large intestine were largely unremarkable, except for slight submucosal fibrosis, which was seen in sections from large intestine. This is the organ complex comprising of the main tracheobronchial tree along with bilateral lungs, which weighed 1,154 grams. Both the lungs showed multiple whitish nodular areas which were better felt than seen, along with a large abscess cavity in the left lower lobe of lung with a fibrosing wall. The tracheobronchial tree was relatively clean and did not show any obvious aspirated material. However, there were multiple enlarged hilar group of lymph nodes. The pleural aspect on the right lobe was overall shiny, however showed areas of nodularity and discoloration on closer view, while the pleura on the left lung showed areas of thickening which corresponded to the underlying abscess cavity in the left lower lobe. This is the closer view to appreciate the cut section of the liver, which shows these multiple whitish nodular areas, along with areas of peribronchial fibrosis and increased collagenization. Some smaller bronchioles also showed presence of inspissated material, and this is the large abscess cavity in the lower lobe with a thick fibrosing wall. This is the closer view of the pleura on the right lung, which shows areas of nodularity and discoloration, and the closer view of the cut section showing multiple whitish nodular areas. These are the representative images from multiple areas, different areas of the liver, which show a near total destruction of the bronchial cartilage and non-visualization of the submucosal glands of the bronchus. And the lumen is almost occluded by exudate, which is rich in fibrinous material, along with many fungal hyphae, which were not only occluding the lumen, but could also be seen infiltrating the surrounding wall. The adjoining lung alveoli were also filled with fibrinous exudate and fresh hemorrhage. On hypar, these fungal hyphae could be discerned as broad aseptate hyphae showing right-angled to occasional acute ankle branching, and were also highlighted on PAS and Grocott staining, morphologically conforming to that of mucormycosis. Further, the sections from the large abscess cavity as well as smaller abscesses within the lung parenchyma showed a lumen which was filled with exudative material, fungal hyphae, along with a fibrosing wall, which was also highlighted on the Mason trichome stain. The pleura in the left lower lobe overlying the abscess cavity was thickened. There was squamous metaplasia of the ectatic bronchus. EVG stain was performed to highlight and delineate the luminal structures, which were highlighted as the bronchial cartilage and the accompanying pulmonary artery. The stain for AFB in the lung sections were negative. However, the Mason trichome stain highlighted interstitial fibrosis. The enlarged hilar group of lymph nodes on microscopic examination also showed a thickened capsule with the loss of nodal architecture due to presence of these atypical population of mononuclear cells. Again, this is the hypar to show this diffuse population of atypical mononuclear cells in the enlarged hilar group of lymph nodes. Further on hypar, these atypical cells could be seen to be 2 to 3 times the size of small mature lymphocytes, having compact nuclei with condensed chromatin and inconspicuous nuclei and a scant amount of cytoplasm. However, there was no significant anisonucleosis or any unduly enlarged cells to suggest a transformation on morphology. Further, the Ki67 index also in these sections was low, around 2 to 3%, excluding a Richter transformation. The gross examination of the esophagus showed mucosal erosions, while the stomach showed diffuse mucosal congestion. The representative microphotograph from the esophagus shows an intact lining epithelium with areas of submucosal hemorrhage. The stomach showed diffuse mucosal congestion, in addition to areas of hemorrhagic necrosis in the muscle wall of the stomach, which on hypar and on PA staining highlighted the presence of these fungal hyphae within the necrotic areas in stomach. This is the organ complex comprising of liver, gallbladder, pancreas and a slice of liver, and a few enlarged peripancreatic lymph nodes are also identified. The liver was overweight for age, weighing 2,360 grams, however did not show any focal lesions, areas of congestion or fatty change. The splenic vein and the portal vein were dissected out grossly and were unremarkable. However, there were multiple enlarged peripancreatic and hilar group of lymph nodes. This is a representative microphotograph from the liver, which shows areas of portal bridging fibrosis, along with infiltration of the portal triads by inflammatory infiltrate. This is the hypar view to show the portal triad infiltration by these inflammatory cells. The surrounding hepatocytes were well maintained. On hypar, these inflammatory infiltrate were seen to be comprising of lymphocytes, some plasma cells and eosinophils, and there was no infiltration by the leukemic cells. Further, there were areas showing centrizonal sinusoidal dilatation and congestion, suggesting features of shock as a terminal event. The reticulin condensation was not there, and hepatitis B core antigen in these sections were negative. Further, the sections from spleen highlighted the thickened capsule, which underlying parenchyma showing depletion of the white pulp. There was periarteriolar infiltration mononuclear cells, which were atypical and similar in morphology as were seen in the bone marrow and hilar group of lymph nodes. The Pearl stain highlighted focal presence of these hemosiderin-containing macrophages. However, there was no overall increase in the hemosiderin content of the spleen. The microscopic sections from the pancreas shows areas of periductal fibrosis along with acina rectaceae, again suggesting features of shock as a terminal event in the organ. The heart on gross examination weighed 233 grams and was grossly unremarkable. The coronaries which were dissected out were also within normal limits. The microscopy sections from the heart showed features of terminal ischemia in form of interstitial edema, variation in the size of the muscle fibers along with atrophy of these muscle fibers, loss of nuclear details as well as hypereosinophilia. There was no inflammation or infiltration by leukemic cells in the heart. The brain on the gross examination weighed 1,182 grams, showed narrowing of sulci with mild tonsillar herniation suggesting cerebral edema. The brainstem and cerebellum were normal on the gross examination. The representative microphotographs from the brain also show mild cerebral edema. The subarachnoid space and the meningeal vessels were normal, and age-appropriate focal calcification was identified in the areas of choroid plexus. However, there was no infiltration by leukemic cells, which was identifiable in the sections from brain. The bilateral kidneys weighed 340 grams and on cut section showed corticomedullary dysfunction. The urinary bladder on cut section showed areas of hemorrhage within the wall. The representative microphotographs from the kidney showed tubular dilatation with shedding of the epithelial cells, interstitial edema, along with presence of many proteinaceous as well as pigment-containing casts. The glomeruli showed areas of patchy basement membrane thickening and stiffening, which was further highlighted beautifully on the PAS stain. The Pearl stain for hemostradin was negative. However, the DAP stain highlighted the RBC breakdown products within the tubules, namely the hematoidin. The direct immunofluorescence performed for IgG, IgA, IgM, C3 in kappa lambda were negative, and the electron microscopy also showed the patchy basement membrane thickening and stiffening. The sections from the urinary bladder showed an intact lining epithelium with areas of submucosal hemorrhage. The right ovary, the bilateral fallopian and uterus were on gross and microscopic examination within normal limits. However, the left ovary had shown a cyst on the gross examination, which microscopically was confirmed to be a hemorrhagic cyst. The skin, thyroid gland and the adrenal gland on gross as well as on microscopic examination were normal, and there was no infiltration by leukemic cells in these organs. So my final autopsy diagnosis in this 40-year-old female with a known diagnosis of CLL is presence of disease in bone marrow, hilar, mesenteric and pericolic group of lymph nodes in spleen, long-standing bronchiectasis with multiple abscesses in lungs, with a large cavitatory abscess in the left lower lobe of fungal etiology, diffuse gastric erosions with a focus of fungal infection, submucosal hemorrhage in esophagus, mild portal triditis with features of shock, terminal ischemic changes in heart, mild cerebral edema, and acute tubular necrosis with patchy basement membrane thickening. Thank you.